Hello, everyone, and thank you for joining us this afternoon. My name is Karen Brownlee, and I am the Adult Program Coordinator at the North Suburban YMCA. In that role, I bring a variety of programs to adults in our community, including social networking opportunities, donation drives, brain games, and the Adult Education Series, which you are attending today. It is my pleasure to welcome you to Illinois Bone and Joint Institute's 9th Virtual Adult Education Series program with the North Suburban YMCA, entitled Rheumatology, Autoimmune, and Chronic Diseases, hosted by Dr. Ami Kothari. Dr. Kothari is a board-certified rheumatologist and is the Director of Rheumatology at Illinois Bone and Joint Institute. She has been with IBJI for 11 years and provides patients with advanced treatments to reduce joint inflammation and help control the workings of the body's immune system. Dr. Kothari did her training at the University of Illinois Chicago and her fellowship training at Northwestern University. Her practice philosophy involves listening to patients carefully to provide a comprehensive evaluation and treatment plan, and to establish a strong doctor-patient relationship. Dr. Kothari remains current on research and clinical developments in rheumatology to always provide state-of-the-art therapeutic options to her patients. She strives to make patient visits as stress-free as possible and works to ultimately provide the highest level of patient care. Her areas of expertise include, but are not limited to, arthritis, both osteo and rheumatoid, muscle pain, muscle inflammation, osteoporosis, bone density and DEXA scan, sciatica, scleroderma, spinal stenosis, epidural steroid injections, fibromyalgia, gout, lupus, joint injection, and the list goes on. Thank you again for joining us this afternoon. We hope that you will learn a lot about rheumatology, autoimmune, and chronic diseases from Dr. Kothari. And now, thank you, Dr. Kothari, for taking the time to be with us today. And please take it from here.
Thank you. Thank you for that lovely introduction. That was very kind of you. And thank you for inviting me to speak. We have many people on this webinar, and I appreciate you guys each taking the time to come and listen to this topic, especially on this really nice, beautiful day. I think maybe one of our last sunny days in November, hopefully not though. I've been very much looking forward to giving this talk, and my goal is to provide you each with a better understanding about the field of rheumatology. As was said earlier, I've been in practice at Illinois Bone and Joint for the last 11 years. I came out and I started here right out of my fellowship from Northwestern. I'm originally from the northern suburbs of Chicago, and I'm practicing in the northern suburbs of Chicago because I love it here so much. I am mainly out of the Morton Grove location a few days a week, and also the Des Plaines location as well. And I see patients at either of those locations 5 days a week. As I said earlier, I trained at UIC for undergrad and also for residency, and then I wanted something a little different, so I did my fellowship at Northwestern and then came straight to Illinois Bone and Joint. I've been here for so long, you can tell that I'm really happy here, and we have a really cohesive group of rheumatologists. We work incredibly well together, and Illinois Bone and Joint in and of itself is such a comprehensive musculoskeletal practice that it's really a physician, and I think even a patient's dream come true, because we have access to all the latest modalities to help treat our patients. We have access to lab, IV therapy, bone density, PT, OT, MRI, CT, ultrasound. The list really goes on, but it's been quite a pleasure and an honor to be a part of this institution. One of the most rewarding aspects about being a rheumatologist is the ability to help patients. I wanted to be a rheumatologist since my first year in medical school a long time ago at this point. And the exciting part about it is that each year that there's more and more treatments that come out. And so medications that I'm prescribing now were actually not even on the market when I first started in practice. And so there's really so many opportunities to help our patients regain their level of function. So in this talk, I'm going to go over what it means to be a rheumatologist, types of diseases that rheumatology treats, and then I'm going to dive more into rheumatoid arthritis. Before I start that, I'm going to go through just some commonly asked questions and scenarios that I see in a typical office visit. So this slide is asking, do you ever wake up with hand pain? Many of us do. The picture to the left shows a normal joint. The picture to the right shows an arthritic joint. So many people don't have hand pain. They wake up, no pain, no swelling, their hands feel perfectly normal. But many people do experience a level of pain, and that could occur throughout all age groups. It could be childhood, because there are juvenile or pediatric rheumatologists, as well as adulthood. Patients can be quite young, and they could also be in their 90s and have hand pain. And the purpose of evaluating the hand pain is to find out the root cause. You don't want to just stick a Band-Aid on it and not know what's going on. Otherwise, the disease can progress. So sometimes people wake up and they have pain at the base of their thumb. So sometimes that's called squaring of the thumb. If you look at your hand, for some people, the thumb is sort of hidden underneath and you could only really see 4 fingers. That's an early sign or early to moderate sign of osteoarthritis. Sometimes people have pain in their knuckles in the areas that are highlighted in red, whether it's in their like main knuckles or up above on at the top levels of the fingers as well. That could be because of just regular arthritis. That could be because of rheumatoid arthritis. Sometimes it could be because of psoriatic arthritis, which is a skin condition along with an arthritic condition. Sometimes people have triggering of their fingers where they wake up or at any point in the day their fingers are locked and you have to take your other hand to unlock that finger. Sometimes that's mechanical, sometimes that's overuse, or sometimes it's like the first clue into an underlying autoimmune process. I always tell patients that the hands are the window to the rest of the body, and subtle changes that we see in the hands represent what's occurring elsewhere too. We often start with getting x-rays of the hands or ultrasounds of the hands because that's a clue in terms of what could be going on elsewhere. And if we find out the root cause, then that can actually help you feel better overall. Sometimes we see patients with back pain. Oftentimes patients are coming into us and they're telling me that their back is hurting. Sometimes their back is hurting first thing in the morning. Sometimes it's hurting late at night. Sometimes they're getting shooting pain going down their legs. Sometimes it's not their back. Sometimes it's their middle back or their upper back, and they're having a headache with it. Sometimes they're having shooting pain going on in the arms. It's important not to chalk it up just to I lifted a heavy box and my back is hurting. You want to make sure that there's no underlying root cause. I think of the back as like a stack of bricks. That's how I describe it to patients. And then each of the bricks is the vertebrae, which is the bones. And in between those bones are the cement, which is the cartilage. Sometimes that cartilage wears down a little bit and those bones come closer together. Sometimes that cartilage or that cement like juts out a little bit and that could press on a nerve. Sometimes around the bones there's inflammation, and that's because your immune system might be attacking your back. So it's important to find out why your back is hurting. Is it mechanical? Is it just because of some wear and tear? Is it autoimmune? Is it because your immune system, which is what's supposed to protect you, has somehow decided to attack your body? Is it because of a fracture? Is there a stress fracture? Did you have like a bad coughing fit and you have like a very subtle fracture in the back? Is it because of something more significant? You always want to rule out the bad things as well. You want to make sure that there's no lesions or no masses occurring in the back as well. So it's important not to ignore pain in the back, but to get it evaluated. So 1, you have peace of mind. 2, again, you find out the root cause. And then 3, you can get an adequate treatment program as well. Have you ever been told your bones are weak? This, I get asked a lot in the clinic. Patients will come in and say, I just had a surgery and my doctor told me that my bones are brittle. Or they'll say, one doctor told me I might have osteopenia or osteoporosis. What does that mean? It's important to know that brittle bones or weak bones are other terms that people are using to describe osteoporosis or osteopenia. That has nothing to do with pain, but everything to do with the quality of the bone. It's like taking a cross section into the bone and looking inside of it. And you're taking a peek inside to see how strong my bones are. Are they really dense? Are they really thick? If I were to fall, I might probably not going to break if they're really strong. Or are they more porous? Are they osteoporotic? Is the density of the bone very thin? It's important to assess the quality of the bone so we know how strong your bones are. We know that if you can safely go into surgery, we know how safe you can exercise. We know that if you fall, that you won't break anything, because it's really about quality of life down the road. From the get-go, you want to make sure you're having a healthy, balanced diet to maintain the quality of the bone. And you also want to assess the quality of the bone with periodic, what's called bone densities. There's special types of x-rays that are looking at the quality of the bone. The minute that the quality of the bone starts to decline, it's important to make an intervention so that years down the road, you don't fall and break your hip. It's not so much a hip fracture or a fracture in the spine or a fracture in the wrist, but it's the long-term implications of that. And it's nice to prevent that. Oftentimes when people have thin bone, their posture starts to change because they're getting subtle fractures in their back, or they're getting other fractures as well too. And it's just so important to maintain the quality of the bone to prevent a fracture requiring surgery, requiring a rehab stay, because someone can go from being really strong and really independent to frail. And we really focus as rheumatologists, as primary care doctors, as physicians across every subspecialty in preventative care. And it's critical to people's overall long-term health. Sometimes we ask, do you ever wonder if you have gout? Gout is an inflammatory condition. Sometimes patients will come in and be like, I think I broke my toe. I had this acute pain and I went to urgent care and they told me that I don't have a broken toe, but it feels like I just can't walk. Gout is a different type of arthritis. It's an inflammatory arthritis, which can affect any joint. The textbooks say it affects the big toe, but it could go anywhere in your body. It is classic in the big toe too. It is one of the most excruciating types of pain. People will wake up at 2, 3 in the morning and think they just broke their toe. They have 10 out of 10 pain. They look at their toes, it's swollen, it's red, it's hot. Sometimes the bed sheet just touching across the toe can cause pain as well. It is one of the most severe pains that people can experience, but it does get better with medication and dietary changes. I tell patients it's one of the most painful types of arthritis when it occurs acutely, but then when we take out the fluid from the joint, it's actually, you see these beautiful crystals. It's not so beautiful for the patient, but that's how we make the diagnosis. In this image, you'll see these like rod-shaped crystals in the purple box, and that's similar to what it looks like under a microscope. It's important not to ignore this, because if you ignore this, then all that inflammation sits in the joint, and then that could cause damage to the joint long term. So once the inflammation is better, there's an erosion in the bone, and then that can cause permanent and long-term pain. So it's really important to get it assessed early by the right physician, and then avoid a recurrence of it as well. So those are just a few examples of the types of issues that I see as a rheumatologist, rheumatologists see as a whole too. It's not limited to just those issues, but I just wanted to kind of highlight some of the key things that people come in to see rheumatology for. So when you see a rheumatologist, what would happen? If you come in to see me or any of my colleagues, we evaluate. We ask you, where is your pain? How long you've had the pain? We ask you about the character of the pain. Is it throbbing? Is it achy? Is it not pins and needles? We really get pretty descriptive in terms of the type of pain that you have to just help make a diagnosis. We also evaluate for any associated symptoms. Sometimes it's not just the joint, but it's something more systemic. Sometimes people can have associated hair loss. Sometimes their eyes can feel dry. They'll describe like a sandpaper sensation to their eyes. Sometimes their mouth can feel dry. Sometimes they could have a rash that comes and goes. Sometimes they start to develop nodules on the joint. Sometimes it's associated with abdominal pain. They could get diarrhea with it. They could get constipation with it. Sometimes people feel really tired, like a midday fatigue, like 2 to 3 o'clock. Like around this time, people feel like they could just go to bed and like go and sleep for hours as well because they're so tired. And it can be a full picture. So when you see the rheumatologist, what we do is try to capture that full picture, not just exactly that joint, but everything else that's going on. We'll also take a very thorough history in terms of what's called the social history to make sure if there's anything else occurring in life, because sometimes stress can bring it on. Stress is a hard thing to quantify in studies, but it's a very common thing that I see in the clinic, that people can be going through a very stressful time in life, and it could trigger an autoimmune disease as well. Then what happens is after we kind of gather all the details, then it involves some blood work, oftentimes some imaging tests as well, and putting all those pieces of the puzzle together is how I would work with the patient to map out a treatment plan. Each person is so different, and no two people are alike, which is what makes it exciting to be a rheumatologist too. But it's important to put those pieces of the puzzle together and find out the root cause of what's going on, rather than just simply giving a pain medicine and not knowing what's occurring underneath too. So what is a rheumatologist? I get asked that question quite a bit. A rheumatologist is a board-certified physician, and we're trained in the treatment and the diagnosis of musculoskeletal and systemic autoimmune conditions. We specialize in the diagnosis and treatment of these conditions and other diseases of the joints and the muscles as well. What that means is that your physician has gone from medical school to a residency program in internal medicine for 3 years, followed by a subspecialization in rheumatology. And that's typically between 2 and 3 years. On average, that's 3 years, with the last year being a research year. We study all the different types of autoimmune diseases, and we also go to our annual training as well too, because the treatments and the options available for patients are changing every year as well. So it's a very exciting field. It's a very fast-paced field in terms of different options for patients, but it's a very hopeful field, because oftentimes I see patients when they're at their worst. They come in and they think that this is how they're supposed to feel, that they're supposed to expect this level of pain. And oftentimes that's simply not the case. It's a matter of getting to that root cause to find out why they're having the pain and treating accordingly. Now, what is an autoimmune condition? An autoimmune condition is when your immune system, which is supposed to protect you, normally it protects you, it decides to go a little bit hyperactive and turn around and attack your body. It occurs when the immune system sends inflammation to areas of the body when it's not needed, which leads to damage and symptoms. The disease can also affect the eye, the skin, the nervous system, and the internal organs. Patients will oftentimes say, well, I could deal with this pain in my joint. I don't want to take anything or do anything about it. But I do oftentimes have to explain that it's not just the joint pain, but it's everything else. The disease can affect your joints, but it can also affect your hair and cause some hair thinning. It can cause some dryness in the eyes, as I was saying earlier. It could cause you to be achy. It could cause you to be tired. And most importantly, it causes inflammation inside the body. That inflammation can damage the eye. It could damage the heart. It could damage the kidney. It could damage the abdominal system, the GI system. And then that inflammation can sit there. And then without appropriate treatment, there's a cancer risk with that inflammation as well. So it's not just limited to one joint or one bad knee or just a hand that hurts. That joint pain is indicative, if it's autoimmune, of something more systemic, which is what a rheumatologist is trying to determine in terms of what is that systemic cause, and then treat it with a more targeted therapy as well. I'll get into more in a little bit in this talk about what that targeted therapy is and what can be done to help patients. So these are some common diseases treated by a rheumatologist. As you can see from that big arrow, I'm going to be diving in more into rheumatoid arthritis in just a little bit. But this is a common list of what rheumatologists treated too, but it's definitely not a comprehensive list. As was said in the introduction, the list does truly go on and on. I treat psoriatic arthritis, which is an autoimmune condition that could affect the skin and also the joints. Oftentimes in those patients, people can have a lot of skin issues, psoriasis, sometimes for up to 10 years. And then they come in and they start to notice that their joints are hurting, meaning that they could have one swollen finger or a swollen toe, or they start to feel tired, they start to feel achy. And it's when the immune system not only attacks their skin, but decides to attack the joints as well. The silver lining with this is oftentimes the medications that treat the skin also treat the joints, so we could streamline the treatment with one medication that'll take care of and help with both. There's ankylosing spondylitis. That was a little bit of what I was referencing to in one of the earlier slides when I was talking about back pain. Ankylosing spondylitis, often referred to as AS, is an autoimmune condition where people have a lot of back pain, inflammatory back pain, which is different than the regular osteoarthritic or wear and tear type back pain. In these patients, their neck can hurt, their mid back can hurt, the low back can hurt. They could feel tired, they could feel achy. Sometimes they get tendinitis in their Achilles tendon in the back of the heel by the ankle. Sometimes the white part of their eye can turn red, which is called uveitis. Those are little clues into a more systemic disease. Ankylosing spondylitis tends to be familial. There's a genetic test for it, but you don't always have to test positive. It's definitely, again, pieces of a puzzle to make that diagnosis. I also treat lupus. You'll see it referred to as SLE or lupus or systemic lupus erythematosus. All those words are used interchangeably. That's when your immune system attacks almost the whole body. People with lupus tend to have hair loss. They tend to have a malar rash, which is what's oftentimes referred to as a butterfly rash along the cheeks. They tend to feel tired and achy. Patients with lupus tend to have cold sores in their nose and their mouth. Sometimes they have kidney involvement. Sometimes they have neurologic or brain involvement, or sometimes they could have what's called brain fog, where they just feel just not totally themselves for different parts of the day. Sometimes they could have joint pain as well. There's so many symptoms. You don't need all of them to have lupus. You can need some of them, but you also need some of the positive blood tests as well. I also treat osteoporosis and osteopenia. That was what I was referencing earlier in terms of the quality of the bone. Osteoporosis is when the bones are very thin. Osteopenia is when they're mildly thin, and then there's normal bones when the bones are not thin at all. It's important to always remember, because we get asked this question a lot, that the osteoporosis and osteopenia have nothing to do with pain, but everything to do with the quality of the bone. And how that's tested for is with a bone density, oftentimes referred to as a DEXA, D-E-X-A scan. I also treat just run-of-the-mill osteoarthritis, wear and tear arthritis, back pain, hip pain, knee pain. Oftentimes that just happens with time, with age, with use. That's treated with physical therapy, occupational therapy, pain medications, oftentimes certain injections like cortisone shots or gel injections, particularly if it's involving the knee, and sometimes also with surgery as well when all the conservative treatment fails too. Also, I treat gout, which I was talking about earlier, and pseudo-gout. Pseudo-gout I get asked about a lot. Is it really gout? What is it? It's a little bit of a misnomer. It's not like a fake version of gout, but it's a different type of crystal that's seen when I take out or when the rheumatologist takes out fluid from the joint. It's treated slightly different from gout, and it's not related to diet the way gout is, but it can occur during periods of stress. We see this a lot when people are in the hospital and they're under stress and they're not eating the same and their body's under stress because they're trying to recover from whatever illness brought them into the hospital. And we see suddenly we'll get called into the hospital because of one big swollen joint, and we take out the fluid and it's pseudo-gout. It's treated with rest, it's treated with fluids, sometimes an injection, and there are certain medications that can treat that as well too. This is just part of the list, but again, the list does go on, but we treat the gamut of different autoimmune diseases. So now, what is rheumatoid arthritis? Rheumatoid arthritis is often referred to as RA, so you'll hear me use those words interchangeably during this talk. But it's the most common form of autoimmune arthritis. It's when your own immune system decides to go a little hyperactive and attack your body. It affects more than 1.3 million Americans. About 75% of rheumatoid arthritis patients are women, but there are many men that get it as well. And I see a cross-section of men and women in my practice with rheumatoid arthritis. 1 to 3% of women may get rheumatoid arthritis in their lifetime. And it's important to know that if you were to see me, let's say you saw me last week and I told you you do not have rheumatoid arthritis, it doesn't mean that you'll never get rheumatoid arthritis, because sometimes it's sitting quiet in the system, and I could see you 10 years later and you do in fact have developed rheumatoid arthritis at that point. So it's important to always keep a watchful eye on your symptoms and never ignore symptoms either. The disease most often begins between the ages of 30 and 50. However, rheumatoid arthritis can start at any age. I'm an adult rheumatologist, so I'll see patients 18 to 30 with rheumatoid arthritis. I'll see patients anywhere between older, between 50 and 90 with rheumatoid arthritis. People can get it at any age. It affects the joints symmetrically, oftentimes both shoulders, elbows, wrists and hands, ankles and feet. It likes to go to the small joints, so it likes to go to the hands first, but it's not symmetric at onset oftentimes. Sometimes it'll start going just to the dominant hand, and if you give it a little bit of time, then you'll notice it'll be in both hands, both elbows, both feet. Just because it's not symmetric doesn't mean that it's not rheumatoid arthritis, because everybody's different and everybody presents differently. So it's always good to get assessed. It does like to go to the hands first, which is the window into determining if it's rheumatoid arthritis, oftentimes, as I was saying earlier. And oftentimes it's associated with a lot of pain and a lot of swelling too. So these are two images that I thought would characterize it well. The image that's listed under swelling just shows a person's hand with just some non-specific swelling. You'll see in their knuckles, there's some swelling. In the middle part of, in the middle knuckles, there's some swelling as well too. Sometimes patients will say that they have difficulty making a fist. It feels tight around the tops of their hands. Sometimes they won't be able to make a fist altogether. They could only make a fist halfway. Patients will oftentimes report that the coffee mug that they were picking up previously, now they have to use two hands to hold it because they feel some weakness in their hand. Oftentimes I'll ask the patient, especially if they're wearing any rings, if they're having trouble getting their rings on and off, because there's so much swelling in the knuckle that they can't pull that ring off anymore. And patients have to either get it resized, unfortunately sometimes even cut off and then get resized later as well. When I'm examining patients, I'm touching all those knuckles. I'm assessing for any swelling, what physicians refer to as synovitis, meaning inflammation around that joint in that joint capsule as well. As a physician's examining, it feels more like a waterbed. It feels boggy. And then it feels tender as well. The patients report pain or they're jumping off the table sometimes as well. It likes to go to the knuckles of the index finger and the third finger, but it can occur anywhere. Oftentimes it'll go to the wrist as well, and patients will have difficulty flexing and extending their wrist as well. If left untreated, it causes what's called ulnar deviation, where the fingers start rotating outwards, which is what you see in this x-ray. What you're seeing in the x-ray is what's called subluxation of the knuckles, meaning that they're sliding outwards a little bit as well, quite a bit in this x-ray. And then with time, it can also cause erosions in those knuckles. What that means is that the inflammation is just sitting there and there's been no intervention to get rid of that inflammation or treat that inflammation, and then there's damage to that joint. When you see a rheumatologist, our goal is to catch this and catch this early and prevent the findings that you're seeing on this x-ray from happening. With the treatments available on the market now, that is entirely possible and it's very common. While there's no cure for rheumatoid arthritis, it is definitely treatable by far. And the treatments have advanced so much in the last 30 years too. So now what causes rheumatoid arthritis? That's what all the scientists are studying. They've been studying this for years. What is known is that it's an autoimmune disease for sure. And it's when the immune system mistakenly sends inflammation to your own healthy tissue. It creates inflammation sent to the joints, causing joint damage as well as joint swelling too. The inflammation can cause erosions, which was what I was referencing earlier when I was showing you that x-ray. Those erosions can sometimes be healed, but if left for a long period of time, it can actually cause fusion of the joint. What I mean by fusion is that you have an inability to extend and flex the wrist. When that fusion occurs, that is irreversible. Sometimes patients do present to me when they already have a fusion, and my goal is to reduce any amount of inflammation in that damaged joint and prevent that from occurring anywhere else in the body as well. The studies have shown that there are certain genes that you're born with that may make you more likely to get rheumatoid arthritis. Tobacco use has been found to be a known trigger. So it's important if you are whether a light smoker or a heavy smoker, now is as good a time as any to try to cut down. It's a very hard thing to quit when someone is using tobacco, but even less, I always tell my patients, whatever you can do, just slowly start cutting down and do the best you can, eventually to nothing as well. but tobacco use in many, many studies has been a known trigger for rheumatoid arthritis. Now, it's not the only trigger, but it's something that's been scientifically proven as well. There are also environmental factors. Years ago, it was thought that people got rheumatoid arthritis because of a gut bacteria. That's been negated in current studies, but we don't know exactly what causes it. There's some sort of environmental triggers. There's been twin studies, familial studies, and that's all currently being researched as well. What I see in my practice, as I was alluding to earlier, is stress does play a role. It's important to take care of yourself. It's important to eat healthy. It's important to rest. It's important to know how much you can and can't do in a given day. And when you aren't feeling well, give yourself a break and rest and focus on the self-care. It's not just what your physician's doing, but it's what you're doing as well. It's your diet, your exercise, your ability to take care of yourself. Easier said than done for each of us, but it definitely does play a role. So what are some symptoms of rheumatoid arthritis? It causes joint pain and swelling that I was discussing, decreased movement in the joints. So decreased ability to make that fist, move the wrist up and down, move the ankle up and down, left to right, even with the elbow as well. Sometimes that curve in the elbow can become a little bit boggy and cause a lot of inflammation. There can be internal organ manifestations. It is not just a disease of the joints. It is definitely a systemic disease, which is important as one of the key takeaway points from this part of the talk as well. Symmetric involvement, it can occur on both sides, but again, it doesn't always start on both sides. I've seen patients that come in classic rheumatoid arthritis, like a textbook. It's the easiest diagnosis, but I've seen some patients that'll come in with just one swollen knee, and they could be like that for years. And then suddenly it'll become more classic as years go on as well too. But it's important to treat each patient, each symptom individually and get a targeted treatment plan. People can get some fatigue, low-grade fever, loss of appetite, dryness in their eyes, dryness in their mouth, morning stiffness as well. That's one of the key features. People will wake up in the morning and say, I feel stiff for like hours. One of my questions I always ask is, how long before you feel as good as you're going to get for the day? Oftentimes patients will report 2 hours, 3 hours. The goal with treatment is to get that to about 20 to 30 minutes or less. And another goal with treatment is to have at least an 80% improvement. I tell my patients, I want to see you have many more good days than bad days and sort of forget that you have this and not realize that you have this, and then maybe have some bad days based on environmental factors and certain triggers in life as well. But definitely it's treatable and people can improve their quality of life for sure. So diagnosis. This is the fascinating and the interesting part of being a rheumatologist. It's definitely pieces to a puzzle. It's never clear cut. It's not just one blood test that'll make or break the diagnosis. It's everything that the patient is bringing to the table with their history, their family history, what has been going on, whether it's acutely for the last week or for the last several years. And family history does play a key role in this. And it's also the environmental factors. What do patients do for work? What have they been exposed to? It's in conjunction with what your physician will do as well. It's the blood work that I would order. It's the ultrasound. It's the x-ray. It's putting all of that together and making a diagnosis. But it's definitely not a one-size-fits-all approach. So these are the different pieces to the puzzle. So when you come in, I would take, as I was referencing earlier, a very thorough history. We have you fill out a form with your history. I know those forms are never pleasant. It seems like a lot of homework when you come to the office, but it's actually very crucial, and we do review those actually quite extensively too. And you want to remember all those pieces to the puzzle when you're coming in. There's no symptom that's too silly. It's always worth it to say everything, because sometimes that little small clue that you didn't think was worthwhile can make or break the diagnosis as well. It's the review of your symptoms. It's all the other manifestations that you could be having. Like, I'm going to ask you if you're feeling tired. Did you lose some hair recently? Do you have a rash? Do you have any nail changes? Do you have any like pitting in the nails? Sometimes that's indicative of psoriatic arthritis. It's rashes on the lower extremities. It's the fatigue. It's the abdominal pain. It's all of those symptoms are very important and critical to remember and to bring to the appointment as well too. It's the past medical history as well. All the illnesses that you may have been diagnosed with, if any, in the past. Sometimes when you have one autoimmune disease, it's associated with another. Oftentimes when people have a thyroid condition, that's on the autoimmune spectrum, so is type 1 diabetes. And it may mean that you're at risk for developing rheumatoid arthritis as well. It's the past surgical history, the social history, specifically the tobacco use and the social history, but any life events. Sometimes there's a major trigger. Sometimes people have gone through a death in the family or a divorce or something really, really major and that can trigger a severe amount of stress. And sometimes that in itself can trigger an autoimmune disease as well. When you come and see us in the office, then I would order some blood work. In the blood work, I'm checking your CBC. That's the blood count. Sometimes when people have a lot of inflammation, they become anemic, meaning that your hemoglobin, which is your blood count, can go down. Sometimes when you have a lot of inflammation, part of the CBC is the platelets. Sometimes those go up. It's a little clue that there's some inflammation in the body. I would check an ESR and a CRP. Those are two markers of inflammation in the blood as well, which are critical to get tested and evaluate. For some people, their ESR is always high. For some people, their CRP is always high. So I like to check both and then continually repeat the one that's staying high to assess that response to therapy. I also check what's called a rheumatoid factor and a CCP antibody. There are two markers in the blood looking for rheumatoid arthritis. They're not diagnostic of rheumatoid arthritis, but they are pieces to that puzzle to put together in conjunction with your history as well. Also check your kidney function, your liver function. All that is critical because based on whatever medicine that we agree to together to start, I would need to make sure that you have nothing else going on or and none of the medications I would potentially give to you would cause you any internal harm as well. Typically, I also order x-rays of the hands to get a baseline. I want to see, are the x-rays normal? Is there any damage there? Are there any erosions or which is the damage to the joints as well too? I want to make sure that there's no subtle stress fracture that's actually causing some of the pain. I want to make sure that there's no chondrocalcinosis, which are like little calcium deposits looking for what's called pseudo-gout, and make sure that it could be nothing else and just the rheumatoid arthritis too. Typically, I also order an ultrasound of the hand, which is a very fun and a newer modality that we're all using, many of us are using for rheumatoid arthritis to establish a baseline. The x-rays look at the bones, but the ultrasound looks for what's called power Doppler activity, meaning synovitis, inflammation. So it's another piece of the puzzle to look for inflammation, to see, is this more inflammatory or is this more degenerative, meaning regular arthritis too? Sometimes it's actually gout, and then we see crystals on the ultrasound as well, or changes that look like crystals on the ultrasound. So it leads the physician in the right direction as well. It's not any of these puzzle pieces alone that make the diagnosis, but it's all of it together. So typically at a first visit, I would do a lot of this. I would take the history, the physical exam, the review of the symptoms, the social history, the x-ray, and order the blood work. And then oftentimes order the ultrasound as well. The blood work can take a little bit of time to come back, sometimes up to 10 days, because a lot of them are very specific blood tests for these autoimmune diseases. So oftentimes I'll start someone off on a medication regimen just to cut down some inflammation and see the patient back 2 weeks later to review all these pieces and then make a diagnosis and move forward from there. So again, the fun part is when we put these pieces to the puzzle together, because there is definitely hope for a lot of patients, most patients, almost all patients, and it's trying to find out that root cause, put this puzzle together, and then get a good treatment plan as well. This is the fun part about being a rheumatologist. There's a lot of gray zone in being a rheumatologist, and it is being a good diagnostician and putting these puzzle pieces together with the help of the patient. It's definitely collaborative. So now treatment. This is an exciting part. There have been significant advances in treatment. I've been at Illinois Bone and Joint for the last 11 years, And even in the last 11 years, I'm seeing new medications come out each year, and each time they're getting better and better. The focus of these medications is definitely on symptom control, but also preventing progression of the disease. Now, there's no cure right now for rheumatoid arthritis, but I hope and I think that in my career, hopefully we'll get there as well too. Some patients do go into remission. It's hard to predict which ones, but we always hope that that does occur. It's not the most common thing to see patients go into remission, but it's definitely a possibility as well too. It's not a one-size-fits-all approach, and so it can be a little bit of a bumpy road in the beginning. It's a stepwise approach based on what's tried and true in some of the older medications to some of the newer medications as well. And right now, a lot of the research is on why does patient A get better with this medicine and patient B get better with this medicine? We don't know that answer yet, but hopefully one day I would hope that there would be more of a targeted therapy approach. But oftentimes it starts with like certain oral medications, and if those don't work, sometimes some injectable medications as well. Early treatment is critical. I always tell patients as well as referring physicians, it's never too early to send your patient to see us or for a patient to come see us. Because if we can see you early, sometimes patients are in that preclinical or like the really early stages of rheumatoid arthritis where you don't necessarily need medication, but it's called a watchful waiting, and it goes one of two ways. Patients either it just quiets down for unknown reasons, or it truly is rheumatoid arthritis and we catch you early and treat you early before there's any damage to the joints. But it's never too late either. So no matter what stage in the disease you are, it's worth it to get an evaluation. Whether you're early, we could prevent the damage. Whether it's late, we could prevent that damage from getting any worse and preventing it from going anywhere else too. Treatments for rheumatoid arthritis can stop joint pain and swelling and prevent joint damage. Early treatment does give better long-term results, but again, it is never too late. I see patients on day one. I see patients when they were chalking it up to so many different other things that it could be, and then it becomes so obvious that it's rheumatoid arthritis, and those patients still have hope and they still do well as well. The medications focus to reduce inflammation, leading to less damage and progression of the disease. And it's not just the joints, it's a systemic disease. So it's causing less inflammation that you'll visibly see on the joints. You'll feel happier, you'll look at your joints, they're less swollen, you'll be moving better. But then by reducing that inflammation, you will hopefully feel less tired, less achy. There will be less risk for eye damage, for heart damage, for lung and kidney damage. It's all the internal organs that I worry about and all rheumatologists worry about as well. It's both. It's your joints, your ability to move, but it's also the internal organs as well. So what are some treatment options? There's NSAIDs. Those are anti-inflammatory medications. Those are like ibuprofen, naproxen. That's like a bit of a fancy Band-Aid. It cuts down inflammation, it'll make you feel better, but it doesn't alter the disease process itself. It doesn't stop the progression. We need those oftentimes in conjunction just to help with pain control, but it doesn't change the progression of the disease. Prednisone, that's like steroids. You'll see it referenced as like prednisone or methylprednisone. There's different variations of it. Rheumatologists use that quite often to reduce inflammation. It doesn't necessarily alter the progression of disease, but oftentimes when people come and see us, they're having so much pain initially that I need to do something acutely to make them feel better while I'm getting all those pieces of the puzzle together and then decide on the most appropriate treatment course. There's also what's called DMARDs. DMARDs are disease-modifying agents. Examples of that are medications like methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. Those are oral medications. Though usually methotrexate is started first line, but again, each patient is different. Each patient's labs are different. Their history is different. Their physical is different. So it's not, again, a one-size-fits-all approach. After that, the next level up is biologics. Those are the injections. You probably see them advertised for all the time, but they're injections that you give yourself or at an infusion center. We have an infusion center at Illinois Bone and Joint where we give these medications quite a bit, but certain medications are given by the patients themselves at home. Certain medications you have to come into the office to get. And these medications are given at various treatment intervals. What I mean by that is some medications are given once a week, some medications are given once a month, some are given every 6 months. They run the gamut across the treatment intervals. I work with the patient to decide based on their lifestyle, based on their risk factors, based on the severity of the disease, what would be the most appropriate treatment. The goal with the DMARDs and the biologics, again, is to prevent the progression of the disease and help the symptoms that you're already having as well, and the progression of diseases for the joint as well as the internal organs. There are new treatments on the horizon. Currently, our annual conference is occurring, and that's online due to COVID. But there are definitely new and exciting treatments on the horizon each year. There are new what's called oral biologics that have been on the market as well for quite some time as well. So each year it does get better and better, but we've come quite a long way between now and even 30 years ago for treatment. Again, definitely exciting times. There's been a better understanding of the disease process, new treatments, as I was saying earlier, on the horizon. And in terms of safety, the long-term safety data is promising, and there are so many what's called randomized trials looking at the safety data. Safety is one of my top priorities, and I always go over with the patient the risks and benefits of each medication to make sure that the benefits do outweigh the risks. When you're on these types of medications, it does involve frequent blood draws because I want to make sure internally there's no damage occurring for the safety of the patient, for peace of mind for the patient and the physician as well too. But there is definitely hope for a better quality of life. It's definitely a partnership. It's not just the rheumatologist telling you what you need to do. It's what you're doing for yourself as well. It's the medication that I was reviewing. It's patient education. It's your rheumatologist talking to you about what disease you have, perhaps the environmental factors contributing to it. And the more you understand about the disease, the better you will be. It involves working with the physical therapist. It involves working with the occupational therapist as well to work with you regarding maintaining an active and vigorous lifestyle as well. Diet and exercise are key. Diet, I get asked this question quite a bit. It's important to follow a normal, balanced, healthy diet. I don't have patients avoid any one food group, but I want them to eat in moderation. That's sort of like the key in life, everything but in moderation too. I get asked a lot, should I avoid dairy? Should I avoid all carbs? Should I avoid nightshades? It's the critical, and my critical answer to that is moderation. An appropriate amount of dairy if you can tolerate it, an appropriate amount of carbs if you can tolerate that. Definitely your fruits, your vegetables, your grains, a bit of each of it. All the basic food groups are important, because if you cut out one, unless you have to cut out one for other reasons, that could trigger another issue as well. So balance is the key with the diet. Definitely not too much processed foods, not too much soda, not too much fast food. As much as you can eat naturally, that's important. Now, I know that's easier said than done, and you do the best that you can with that. Exercise is important. Oftentimes, I do refer to physical therapy and occupational therapy to get someone going that's not necessarily used to exercising. Some people are avid exercisers, which is great. Unless there is a reason, there is no limitation. The more you move, the better. Now, you don't want to do that in excess, but again, balance with the exercise. Stretching, Tai Chi, yoga, aerobic activity, weightlifting, all in moderation, but it's all important. You definitely don't need to be bedbound. The more you move, the better, because then your joints will feel less stiff and you'll feel stronger as well. So as I was saying, a healthy, balanced diet is critical. It goes back to what we all learned a long time ago with the food pyramid, and I still follow that as well. Regular, low-impact exercises, definitely periods of rest. You want to give yourself a break because it's an autoimmune condition, and oftentimes people have midday fatigue, like around 2 to 3 o'clock. I tell patients, if they're able, try to just rest, whether you have to just sit down for 30 minutes, but take care of yourself. I don't want anyone to sleep for hours in the afternoon. Otherwise, you almost feel too lethargic when you wake up. But periods of rest, if you're able, based on your lifestyle, as well as medical treatment too. It's not any one of these alone, but it's all of it together that I think is the key to success. And it's definitely a partnership with your rheumatologist. So when should I see a rheumatologist? So many patients experience muscle and joint pain, but when the pain is not resolving, I think an additional evaluation is needed. Or if any of these points that I highlighted today hit home with you, then I think an evaluation is needed as well. It's never too early, it's never silly, but it's always important to get evaluated and get a good baseline. It's critical for peace of mind as well. And now I'll open it up to questions.
All right, and Karen's back with the questions. I have a lot of them for you. I've tried to kind of combine them so that we can try to address them and figure out what order. So
No problem.
you mentioned seeing a rheumatologist. If
Yes.
someone has joint pain, should they see an orthopedic person first or a rheumatologist first, or how does one decide?
That's a really good question. And as everyone knows, clearly, I work with Illinois Bone and Joint. And so the orthopedic surgeons at our group are so well versed, and they're phenomenal. And oftentimes a patient with hand pain will end up seeing the hand surgeon first, and the hand surgeon will take one look and be like, this is not me, this is not surgical, go see the rheumatologist, and vice versa. Sometimes I'll see a patient that I'm like, you have to go see the hand surgeon. So we toggle back and forth a bit, but if you're having pain, if you're having swelling, if you're having stiffness, you would definitely, I would think, see the rheumatologist first. We evaluate, and then based on what the need is, then I send straight to the hand surgeon if that's needed as well too.
Great, thank you. You had mentioned seeing a rheumatologist so that things don't progress. And
Yes.
some questions have come in, like how quickly? You know, do things break down to the point where you might have joint damage within days, weeks, months, years? How quickly should someone try to get in?
Normally months, it's not days. So I don't want everyone to be on this call, especially to be alarmed that, oh my God, my knee is swollen, I'm going to have all these erosions. That doesn't occur by any means too. But as soon as you can get in, sometimes in some areas, there is a delay to see a rheumatologist because there actually are a shortage of rheumatologists in certain areas across the country. We're lucky in the suburbs that we're at that there are plenty of rheumatologists. For some, there is a little bit of a wait, but it's definitely important. I would say within months, but the sooner the better.
Okay,
as well
great.
too. Yeah.
Thank you. There have been a bunch of different questions about treatment. People have asked about stem cell treatment. People have asked about medical cannabis. People have asked about a variety of other things. What are your thoughts on those two things? There was a third one that I'll find as well.
Okay. For stem cell, it's still early, so it's not the routine standard of care for stem cell. I've had patients that have gotten stem cell treatment and they've gotten benefit. I've had many that have gotten it and not gotten benefit. I feel that in a lot of cases it's quite expensive, and I think there's still some ways to go with the research, but I'm excited about the possibility of what it can offer in the future. In terms of medical cannabis, that can help in terms of pain, but it doesn't help the disease process as far as the literature shows right now too. My patients that have gotten relief from the medical cannabis tend to like the more, the creams, like the lotions to rub on whatever is hurting as well too. Or sometimes they'll use certain items to help them sleep, because if you have a better night's rest, you have less pain. But I don't want that to be used as like a fancy Band-Aid and then like the disease itself progresses. So that in conjunction with treatment is my recommendation if a patient sees it.
Great. And then the third question about treatment types was electrotherapy. What are your thoughts on that?
So there's not a randomized trial that I'm aware of that shows benefit, but anecdotally, people do have benefit from it. So I don't think it's going to hurt. Don't quote me on that, but it's worth it. You could try it, and that's fine.
Okay, great. And then I'd like to talk about bones a little bit. Someone
Yeah.
asked, do all medications negatively affect the bones?
Do all medications? No, not all medications negatively affect the bones. With every medication, whether it's Tylenol, Advil, Aleve, all these medications have like the risks and the benefits for each of them too. And then based on the patient profile, meaning the symptoms, their lab values, then that can be determined for sure.
Great, thank you. And regarding bones, people have mentioned that their doctors have told them they have soft bones. Would you know what that means? I had a number of questions about that.
Yeah, so I should have used that word soft in the beginning. So yeah, people will say that their doctors told them that they have soft bones, weak bones, brittle bones. Those are all the terms that your doctor's using or people are saying to describe osteoporosis or osteopenia, meaning that the quality of the bone is thin. Again, nothing to do with the pain, but the quality of the bone. As a rheumatologist, we all treat that quite extensively. I treat that all the time. And that's evaluated with a bone density, which is like a little bit of a fancy x-ray to assess the quality of the bone. And then based on that and blood work to determine different treatments. There's supplements and also pharmaceutical medications for that.
Great, great, thank you. We're in vaccine season. What are your thoughts on vaccinations for people with autoimmune diseases?
I think that when people have autoimmune diseases, especially when they're on treatment, they are immunocompromised. And so unless there's a contraindication by the primary care physician, I think that the flu shot now more than ever is necessary because there's so much overlap between flu symptoms and COVID symptoms. If you are on medications, there are certain medications like methotrexate that it is recommended to hold 1 to 2 weeks after the flu shot. And I would let each of your physicians guide you on that as well, because each patient's profile is a little bit different. But the flu shot, as long as you could tolerate it and you haven't had an adverse reaction before, I would definitely advise.
Great, thank you, thank you. Someone asked, what are the symptoms of internal organs being affected by rheumatoid arthritis? Would the patient see those, or is that something that you would see only as the doctor?
So as a physician, I would see that. I would see that the liver tests are going up, the creatinine, which is a kidney function marker, goes up. Some patients will notice it when people can get what's called rheumatoid eye, where they have decreased visual acuity, like their vision gets a little bit blurry or foggy. When sometimes it's associated with heart disease. Rheumatoid arthritis can be associated with heart disease, like inflammation of the coronary vessels as well. So we ourselves, or we have the primary check the cholesterol once a year as well too. So patients will notice some, but when you get to know your rheumatologist, you'll sort of learn over time that we're always checking blood work.
Got it. Great, great. Someone mentioned that they have blue nodules under the skin near the joint of some of their fingers on their hand. Would that be something that a rheumatologist could help diagnose?
Yes, so you can get nodules because of osteoarthritis, they're fancy names. They're called Heberden and Bouchard's nodes. It's just a fancy way to say you got some bone spurs underneath there too. You could get nodules because of rheumatoid arthritis. You could get nodules because of gout as well too. And sometimes when those open up, it looks like chalk that's draining out a little bit. So there's different reasons to get the nodules, but yeah, that's definitely something that rheumatology sees quite often in diagnosis.
Okay, great. This was an interesting question. I don't know what your thoughts are on it, but are nightshade plants like tomatoes and peppers really contributing to rheumatism?
So there have been, I get that question a lot. And I always go back to that food pyramid, just like the basic healthy balanced diet. I mean, life is short. I want everyone to enjoy. I want people to eat well, but just balanced and healthy, not too much of each individual group is my recommendation for that too.
Okay, how about organics?
Organics are, I think, good. Personally, I like to eat organic as much as possible too. I think it's just cleaner in terms of possible toxins that could be in it. I think there's so much that we don't know. So if we could err on the side of caution, that's always better.
Great, great, thank you. Is stenosis a part of rheumatology?
Stenosis, like oftentimes we use the word stenosis when we refer to the back, like spinal stenosis, meaning that the canal is narrowed. We see a lot of patients with spinal stenosis. We manage the pain aspect of it. So like a lot of times pain medications, I refer to physical therapy quite a bit, order the MRI. If like it's time for an injection, I always refer to one of our pain doctors, and then they handle definitely the injection part of it as well if that's needed.
Got it, got it. And I don't know how to pronounce it, Sjorgrens.
Yeah, Sjogren's syndrome. So that's when that's dryness in the eyes and dryness in the mouth primarily, but it has systemic issues as well. That's autoimmune too. Sometimes people with rheumatoid arthritis can get what's called secondary Sjogren's. They have rheumatoid arthritis, but they have lots of dryness in their eyes and their mouth. Sometimes people have primary Sjogren's, where that's their main disease as well. Rheumatology definitely treats that.
And do people end up with joint replacements often because they have that? There were a couple of people who referred to that.
With Sjogren's syndrome or with rheumatoid arthritis, people can, or any of these autoimmune diseases, yes, people can have joint replacements, but when they're having joint replacement, like if you need your hip replaced or your knee replaced, that's because of osteoarthritis, like wear and tear as well. And you can get both. I tell my patients, you got lucky, you got both. You got rheumatoid and you got osteoarthritis.
Ooh.
And then we work, yeah, and so then we work with the surgeons. They'll get their hip or their knee replaced, but it doesn't mean that that's going to fix their rheumatoid. It helped with their osteoarthritis, but they still have the rheumatoid arthritis as well,
Gotcha.
too.
Gotcha. Well, I can't thank you enough, Dr. Kothari.
Thank you for having me. This was fun. I hope everyone enjoyed it, and thank you all for coming.
Absolutely. We got through most of the questions. I know some were pretty specific. So for those of you who have very specific questions, Dr. Kothari's information is on the screen for you. You can reach out to her, make an appointment with her or one of her colleagues. And Dr. Kothari, thank you so much. It was very informative. Thank you for putting it into lay terms so we didn't have to try to pronounce so many unusual words. I appreciate it. And thank you all for joining us today. This was really informative, and I hope that everybody got something out of it. And Dr. Kothari, thank you again so much for your time.
Thank you. Thank you, guys. Have a good, enjoy the day.